Dear colleagues, we continue our meeting. Deputy Director of King Hussein Cancer Center from Jordan will deliver several lectures dedicated to their own experience of treating patients at Jordan Center. So I would like to say that starting tomorrow, 12 p.m., I would like to invite everyone, those who has experience, those who don't, to attend Dr. Hassan's lectures on transplantology and genetics, and it's primarily dedicated to children's oncology, but there are some mutual topics that could be interesting for everyone. Mr. Jamal?
Yeah, good afternoon, everyone, and thank you so much for coming today to attend this talk. And this is actually about some update on the treatment of the prostate cancer. So I'll be speaking mainly about the new technology that's being used nowadays or considered to be for prostate cancer, which is a stereotactic body radiotherapy for treating definitely the prostate cancer. So I'll be talking about the incidence of prostate cancer globally and in Jordan and then in Ukraine as well, and also the management options for organ-confined prostate cancer. And when we say organ-confined prostate cancer, we mean the low-risk, intermediate, and high-risk group of patients, and talking mainly about the new tool of treating definitely not for bone metastasis or for oligometastasis, but a prostate by the SBRT, stereotactic body radiotherapy, or sometimes called stereotactic ablative radiotherapy as a curative therapy for prostate cancer. So according to the GloboCan 2020, in general, globally, prostate cancer, it is the fourth most common cancers diagnosed, and the mortality is number 8. So this is really a common problem of prostate cancer, where more about 1,400,000 people are being diagnosed with prostate cancer globally. Now, if you can see here, the incidence in Western countries and the U.S. and in Europe, West Europe, is more than in Africa and Middle East or Far East, but still the mortality is more in Africa because of the lack of the treatment tools and also the late presentation. So if you look at in Ukraine here, the cancer incidence in general, according to the GloboCan 2020, the latest report, you will be having around 162 or a bit more new cancer patients for the population, which is about 44 million, and the mortality is about 85,000. And if you look at the prostate here in Ukraine, it is number 4, the most common. It constitutes about 7% of cancer patients diagnosed here in Ukraine. You have a prostate cancer, and in male, it is number 2 after lung. So we know, urologists also, radiation oncologists, we know when we diagnose patients with a prostate cancer, there are many ways of a treatment, and that is according to the stage of the disease, with a very, very low risk, intermediate, or high risk group, and that is, we are talking about organ confined disease and not metastatic one. So we have active surveillance, just watch and see and do periodic PSA and biopsies, watchful and waiting for patients with life expectancy less than 5 years. Probably you can just watch and wait and treat when the patient develops some symptoms. Surgery is a very important tool for prostate cancer. Brachytherapy as well can give the same results, and external beam radiotherapy. And this all, mainly surgery, brachytherapy, and external with or without hormonal therapy, depending upon the risky group of the patient. Low risk, there is no need at all for hormonotherapy. For intermediate risky group, when you have a glycerin score 7, BSA between 10 and 20, until T2C, both loops are involved, then maybe 6 months hormonotherapy. For the high risky group, if you have BSA more than 20, the glycerin score 8 to 10, or T3A beyond the capsule or similar physical involvement, 2 to 3 years hormonotherapy is needed. So what I'll talk today, one of the arms to be considered for treating prostate cancer is the external beam radiotherapy, and what advanced technology we have now, and evidence to support its use. So we know probably for the last 20 years that for the organ confined, surgery and radiotherapy, whether it is a brachytherapy or external beam, they give the same results. So that's why you discuss with your patients about the options of the treatment. Now, what developments we have in radiation oncology? We started with two-dimensional planning, shifted to the three-dimensional. Then now we have the IMRT, we have the PMAT, we have the proton therapy, and also as we have this advance in technology of radiation oncology, we have it in surgery. You know, we started with the open, still open, can be considered in some patients, or open prostatectomy, or the laparoscopic, or in that one, although it's not clear, that is the Da Vinci, which is the laparoscopic, the robotic prostatectomy. So there are some developments in the technology as the time goes. So radiotherapy, conventionally, we used to give 72 gray because we cannot buy 3D or 2D give more, because the toxicity to the rectum, what we call GI toxicity, and also to the bladder or GO, it's a lot. That's why we just limited to 72 gray and 36 fractions. But when you use IMRT and the VMAT with the new technology, so that is focusing the radiation to the tumor with minimal involvements of the organ at risk around, we increase the dose to 78 up to 81. But that is in 38 to 41 fractions, meaning that the patient has to come for treatment for almost 2 months. Now then, when we have the new technology, and we know the prostate cancer radiobiologically, that if you give more, the alpha-theta ratio is low, less than 3, so there is a benefit from increasing the dose and decreasing the number of the fractions. It works in prostate cancer. So we shifted from the long one, 2 months, to just 1 month, 20 fractions. And we, in my hospital, we changed to the moderate hypofractionation for the last 3 years. We use only for 20 fractions, 60 gray, and that is for 1 month, every day except 2 days, like here, Saturday, Sunday, but we have it there Friday and Saturday. So people now think, why not to go for more dose per fraction, less number of the fractions, what we call the SBRT, stereotactic body radiotherapy, or this is another form, ultra-hypofractionation, that is only considering 5 to 7 fraction, and that's it. Patient comes, you do a CT simulation, 3 times a week, every other day fraction, 2 weeks, treatment is over. So there is no need for 2 months, there is no need for 1 month, it is only 2 weeks, every other day, and that's it. So the dose, when we say SBRT or stereotactic body radiotherapy, the number of fractions less than 10 or 9 should be. More than 10, it won't be called as the SBRT, is the hypofractionation usually. And the dose should be between 5 gray to 20 gray per fraction, rather than the conventional that we treat 1.8 to 2 gray per fraction. So here, the number used usually nowadays, when they started as trials and now as practice, standard of care, between 5 to 7 fractions. Now, I don't know, it's not the last line is not there. Now, there are some trials to consider 1 fraction only, and they call it the shot. It's like a shot, only 1 day. 1 day, ask the patient to come, There are some trials going on, but it's not finalized yet. We have to wait. Do the CT simulation or MRI simulation, do the plan. The patient comes, one treatment, 19 gray, just in one fraction, and that's it. But still, we have to wait. So maybe as we are changing our practice for treating prostate cancer by radiotherapy, maybe the day will come after a few years that radiotherapy will be from 2 months to one fraction only. So why it is important to speak to you about the SBRT? Because actually now it is the hot topic in the urology, in the radiation oncology for the prostate. And if you can search in the PubMed, you will find more than 700 articles published on just the topic of the SBRT of the prostate. Now, okay, if you want to start in your department this service, always you should have evidence. Without evidence, without thinking together as a urology department or radiation oncology or the multidisciplinary team, you cannot start any new procedure. And this applies to here, the SBRT prostate, or any other services or any other new technology or new protocol of treatment. You should discuss it, and you should, before that, have international evidence. So what evidence we have to change our practice if we have the expertise and if we have the technology also? Because if you have 2D or 3D or cobalt, you cannot start SBRT. But if you have the image-guided radiotherapy, if you have the technology, the VMAT, then probably you can. And that I'll discuss it in more details later on. So how this story of the SBRT started? It started with this article 10 years ago when for bone metastasis, for brain SRS, very high dose, number of, why not to prostate? Can the time come really that we'll consider it for the prostate? And he published this in the oncology hematology. Will SBRT replace our? He asked this 10 years ago, and now we are changing our practice to SBRT. So sometimes you need more randomized trials to prove your idea, then you can practice it. So what we have to discuss with our patients or among our team to convince the patients and also our team that SBRT can work and we can consider it for our patients. Now there are from actually 2019, just before COVID-19, it was the explosion of articles about the results of the SBRT. Most of these studies were published in 2019. The HypoRT prostate cancer randomized trial, which was done in Sweden and Denmark. The other one, the Bsp randomized trial, and the systematic review and meta-analysis, which we know it is the highest evidence, and followed by that is the randomized phase 3 trial, that to prove its efficacy and it can be used as a daily practice. And now it is in guidelines of the NCCN since 2019 that SBRT can be used safely for treating of organ-confined prostate cancer. Now this article, the first one, there are 3, so I'll just go through it fast. And now this is the ultra-hypofractionation versus conventional fractionated radiotherapy for the prostate cancer, 5 years outcome of the HypoRT BC randomized non-inferiority phase 3 trial, right? And as I mentioned, this was published in 2019 in The Lancet Oncology, and here the schedule that they use 7 fractions, 42.7 gray in 7 fractions, which is 2 weeks and treatment is over, and they treated 1,200 patients. And the conclusion there down that it is non-inferiority, it is the same results as the outcome biochemical control comparing with the external beam radiotherapy, which takes 2 months. You can do it from your side if I'll tell you next. Okay, so the conclusion criteria in their study, the below 75, even 74, 73, don't think so old, I cannot give SBRT. Up to 75 you consider. Performance status 0 to 2. Still, people are coming not in that good general condition. Up to 2 performance you can still consider it. So they did CT scan here for planning, not MRI here, but the CT scan with the thickness of 3 millimeter, full bladder with empty rectum. Next, please. So as I mentioned, the protocol that in this study, 7 fractions, 6.1 gray per fraction, and that is total 2 weeks and treatment is over. Next, please. So this is the randomization between the two. But you see here, because they had some bladder side effects more than expected, you see here that 80% of those patients were treated by 3D, not by the new technology IMRT or VMAT. That's why they had some more in the GU toxicities. You can see 3Ds, 80%, 20% VMAT and IMRT. Next, please. And so the outcome is the same. The biochemical control of the BSA in the 5 years is the same, whether you treat by the conventional radiotherapy, that is 2 months, or by the hypofractionation or the SBRT, the ultra-hypofraction, is the same result. The control is the same. Next, please. But if you see here, the side effects for the rectal down, it is the same, roughly. But up, the bladder, although statistically was not significant, but still the SBRT arm was more the side effects. And they said it's because the technology used is not the latest one, is not the VMAT IMRT, where you really confirm your dose to the prostate and with less dose to the bladder and rectum. But the 3D, no, it is more. The dose will go more to the bladder. That's why they have more side effects. Next, please. So in their conclusion, this study, that we found that the ultra-hypofractionation or the SBRT is non-inferior, it's equal to conventional fractionation radiotherapy with acceptable side effects, and they concluded that introduction of ultra-hypofractionation or SBRT with image-guided radiotherapy techniques would offer added patient convenience, because he will come just for 5 or 7 days. He will not come for 2 months for treatment, and significantly reduce the radiotherapy department, the load. So you can treat so many patients while taking the same time treating one patient for 2 months. So it is really something to think about. Next, please. The other evidence, the other very important article, Bsp Trial, and again in 2019 published, it is they use the not 3D, it is the IMRT, the new technology like a VMAT for radiation oncology. So you need really to have a technology versus a stereotactic radiotherapy for prostate cancer. It is again a randomized phase 3 trial, non-inferiority. Next, please. And they stratified the patient. This is hypofractionation, the usual 1 month, and also conventional 2 months with the 5, actually, not 7 fractions. In this study, 5 fractions only. 400 in this arm, 400 patients this arm. Next, please. And this is a good stratification between the 2 arms, patients with 5 fractions and patients with 2 months or 1 month of radiotherapy. Next, please. And they found the GU, that's the bladder, and the rectal side effects almost the same. And better than the previous study because they use the technology, not the advanced, the 3D. Here, they use the IMRT and the hypofractionation. So here it is much better. So it is the same side effects. Next, please. So their conclusion, again, suggested higher patients reported toxicity with ultra-hypofractionation by contrast, which is the previous study. But in their study, our results suggest that substantially shortening the treatment courses, just 5 days, 5 fractions in 2 weeks. You can treat the first week 3 and 2 in the second week. Courses with the SBRT doesn't increase either GI or GU. So this is your patient needs to know that this arm, that if I'll treat you by 5 fractions, the side effects, the late or the acute, will not be much different than the conventional one. Next, please. Now, this is the the last piece of evidence to support the SBRT, which is the highest level of the evidence, what we call the meta-analysis, the systematic review on meta-analysis, which was published just last year, 2020. So this is again to compare patients treated by SBRT and other in more than 6,000 patients, about 6,100 something that are treated by SBRT. Next, please. You can see here the number 6,116 patients treated by the SBRT, and with a good follow-up between 1 year up to 7 years. And you can see the outcome is very important, very, very impressive one, that the outcome is around 95% that you have, at least for 5 years, control of the PSA without any biochemical relapse. Next, please. So you see these are some trials that were included in this meta-analysis, and they started with low risk and some with intermediate, and even some studies, they included the high-risk patients also in their studies. But still, it's really meant for low and intermediate risk patients, patients with a BSA less than 10 or 20, glycemic score 7 or 6, and up to T2C, the involvement in the prostate, nothing outside the capsular prostate. Next, please. And you can see here the meta-analysis studies. There were prospective randomized studies, about 14. I just mentioned 3, but there are 14 one. And again, the mostly used one is 7.25. And here you can see that mostly are T1, T2, although some of them high risk T3. And also some of them, 19 trials, they used hormone therapy as well. Next, please. So you can see here their definition for meta-analysis, that the number of fractions should be less than 10 to consider it as the SBRT, and the dose per fraction should be more than 5 gray. If it is 3 or 4, it's not SBRT. It's hypofractionation usual. But to make it, to label it as SBRT, you need more than 5 gray. So, yeah, next, please. So they found also the low intermediate risk, the control of the disease about, in 5 years, about 96.7, and for the intermediate, 92.1. Almost like the external and like surgery, if not better even. Next, please. And you can see here at 2 years, at 3, at 5 years, local control is 95, and even up to 10 years. And you can see if the 5 years here, local control is exactly, if not a bit better than external beam and surgery as well. Next, please. So again, with the acceptable, the urinary and bowel side effects, and even the sexual activity. Next, please. So they conclude in this meta-analysis, which is the highest level of evidence, that our findings support SBRT could be considered as a standard strategy radiotherapy for localized prostate cancer. And now there are some ongoing study to assess its potential superiority better. Now we know it's equal, but now there are some studies are ongoing to show the SBRT even better than the surgery or the conventional radiotherapy. Next, please. This is the study which is going on, the NGR-GU005 trial, to show superiority of the SBRT than surgery or conventional. But still, we have to wait the result. We don't know the answer, whether it is better or not, but at least it is as equal as the conventional or as surgery. Next, please. Now, so the evidence, do we have retrospective studies? Yes. Do we have randomized clinical study? Yes. Do we have meta-analysis to support its use? And the answer is yes. So any department, if we'll start, if they have any department, if the faculty has the experience, and that is the doctors, the medical physics, and the technologists together, and the technology. They should have the machines that they have image-guided radiotherapy. Without it, you cannot treat. And also, if you have, of course, the VMAT or the IMRT, you can use it. So if you have the human resource and the technology, you can use it as a standard of care in your department. But if you cannot have one of them, you cannot really start it. Next, please. So it is good for patients because it's the time is very few fractions, only side effects is the same. Probably the price or the cost will be hopefully less because, you know, for the load for the patients, for 2 months you can treat like 10 patients. But here you can just treat it for a few days. And even by using the new technology, the VMAT, the actual treatment is just a few minutes. The whole setup is 15 minutes, but the actual treatment is 3-4 minutes, and the treatment is over. So there are many advantages to consider SBRT. Next, please. So is it there in the NCCN guidelines? The answer is yes, and that is from 2019. Next, please. It is there in the NCCN guidelines that ultra-hypofractionation, or the SBRT, can be used in the very low or low, intermediate, and even the unfavorable intermediate when you have a glycerin 7 plus 4 plus 3, they call it unfavorable. You can easily consider it. Now, for us, just recently, we formed, this is my department, no, just one before, please. This is my, I don't know why it's not clear here. Anyhow, so this is my staff here, and I'm really proud to be one of them, where the technology, it's a team. It's not only one doctor, he will do it, no. It is the team. It is the doctor, I'm here, my colleague, another radiation oncologist, Dr. Ramiz, coordinator nurse for education is very important. She takes that part. And also the other, and Dr. Sarah is here, and the medical physics, we have 2, and also we have the technologists. All will sit together, think about the protocols, what we have, what patients to select, and how to treat, and who will do from the medical physicist, who will do the plan. And from the technologist radiation, who will treat the patients, because we have about 30. Not each and every one will be trained to do that. We'll start with 3, right? And then we'll expand that for the future to be anyone can treat. But you should start at a point, and we started from this group. Next, please. So also we worked, since we do not have an MR dedicated, which is not a mandatory, just to fuse the MR with CT, we also had a discussion with our chief of radiologists and our also colleague, Dr. Muhammad, who sits with us in the GU multidisciplinary team. He's always there as a radiologist for the GU cases, and myself here. So we put the plan, we put some guidelines to do the CT simulation and immediately take the patient to the radiology department to do MRI in the same position and do the fusion. Because probably prostate is one of the sites that MRI will give you more information, more accuracy in the imaging rather than the CT. We know in the rectal cancer, prostate cancer, pancreatic cancer, brain, CNS, MRI is better than the CT. So we have also discussion with our colleagues as a team. We work always as a team. Next, please. And this we are now ordering one MR paste for the treatment and for the simulation. Hopefully within a year from now, we will have 2 machines. Next, please. Because sometimes really it is very important for the localization of the prostate to use this is the MRI and this is the CT to have a fusion together. Next, please. So whenever we thought that whenever we will introduce any new technology, it should be discussed within the team that I formed, and then to the department staff to discuss it and to see their views, and also to the GU multidisciplinary clinic. And then last 2 weeks ago, I presented as grand round, as a lecture to the whole hospital, that we are going to start a new technology. These are the requirements. This is the evidence to support. And now, in the coming few weeks, we will start it. And probably we are the first center in Jordan and probably in the region to start SBRT for prostate. Next, please. So, and here is the importance of the twinning. and also collaborative agreement. We have a collaborative agreement with Princess Margaret Hospital with the team, right? And one of that, we thought together to adopt their actually fraction, which is 7 fraction, like the first paper I mentioned. And also we had 2 or 3 Zoom meetings to discuss this procedure and to go with it. Please, next. So which patient to select? We also identify which patient to be selected for the SBRT, low risk and intermediate risk, and only some selected cases from high risk. If only slightly BSA is above 20, that makes this patient is a high-risk group. Otherwise, the glycemic score should be less than 7 or less, and T1, T2 maybe can also be considered for SBRT. Age up to 75, like what is there in literature, with performance, again, 0 to 2, please. Now, some patients not to be considered if you have, for SBRT, if you have very large prostate, very worrisome or troubling symptoms, and patients with Crohn's disease or acute GI disease where you cannot really give a high dose for the pelvis. Probably those patients are not good to be considered for SBRT. So it's a simple, full bladder, empty rectum. It's the only preparation. You do CT or MRI, and then use the VMAT as a technology, and the dose the same one that is in the first paper I mentioned, and the protocol, Princess Margaret Hospital in Canada, 42.7 in 7 fractions. Next, please. So now it's over. This question is over. We know it is effective. We know it is non-inferior. It's equal results. Now there are some ongoing studies to show, as I told you, it is superior than surgery and conventional. And also it might be used, like in San Francisco, there is a trial now by Professor Roche, considering as a boost, just 2 fractions boost after the treatment by usual radiotherapy. And also, as I told you, just not to make it 5 or 7 like nowadays we use, and many centers are using just 1 shot or 3 shots, that's it. So in 1 week or 1 day you finish the treatment. The answer for this probably will take few years from now. So this is one of the articles published in recently in March this year, toxicity and 1 year after stereotactic for 3 fractions. So now they said we don't want to go for 5, 7. Probably that is too much. Let's try for less. But I don't advise now to start unless we have some a concrete result of this. So you may start with 5 and 7, not by 3. But just to let you know what's going on in this field. Next, please. And what they concluded in this study for 3 fraction, results suggest that 1 month after, 12 months or 1 year after treatment, that toxicity profile for SPN3 is acceptable. So the side effects is really good. I mean, it's not worse than the 5 or 7 fractions. Next, please. Again, now another article 2. So either 3 or 2. They're comparing with 5 a fraction, and they want to see the results. Next, please. And this, look at this article. 1 shot only, and this was published in 2018. Single shot radiotherapy, and that's it. And the day may come after a few years that patient will be treated with 1 shot radiotherapy, and that's it. And the dose 19 gray per 1 fraction, that's it. Next, please. To conclude in my talk here, we have evidence to support the use of the SBRT if we have the technology and the expertise. And we actually at King Hussein Cancer Center, we do have the technology, the latest machine we have, and also we have very experienced medical physicists, technologists, and doctors to start it. Because without having the experience, just to jump to the new technology and high dose fraction, a bit risky. So you have to take care of that. And always that should be among the multidisciplinary approach. No one should decide what is the treatment or to start any initiation, any steps or any new technology without discussing among the team, in which there would be urologist, medical oncologist, radiation oncologist, pathologist, nuclear medicine, and radiologist. Nurse is very important. Nurses, by the way, it's always they are a part of our team. We have 1,100 specialized nurses. And all of them, really, the level of education they have, especially in cancer, is always there. They continue medical education also. Don't forget the nurses. They are very important part of the team to play. Now, for this, they take the educational part of and follow up with the patients. They take part in that. So multidisciplinary approach is really very important. Next. So this is some photos from Jordan. This is the Jerash, which is the Roman city, and I think Dr. Gregory, he had the chance to visit, which is just 45 minutes away from Amman. If anyone is planning to come to Jordan, you're most welcome. There are many places to be seen and some of our traditional folk dance here. So thank you so much. And if any question, I'm happy to answer.
Thank you so much for the presentation. We expect that maybe next year we will have, we hope that we will have some new technologies available in the institute. So the first question about your own experience, clinical doctor. So how many have you done in your department? We are talking about the localized prostate cancer.
Right.
And what was the learning curve to move from one method to another one?
Right. Good. A good, very good question. And now, for SBRT, still, actually, this lecture, I gave it just a few days to the hospital that we have the technology, the evidence, and we did not treat any patient. And if you see, even in USA and in Western countries, UK, many centers, they did not start it because it's new. All the publication 2019, guidelines 2019, and then came COVID-19, so that's limited our practice. So we will be in the coming weeks presenting or starting offering our patient the SBRT. But before that, I mean, for the last 3 years, we treated our patients not with the conventional one, that is 2 months, 78 or to 81, but with 60 and 20. This is the hypofractionation. And actually the experience that we have is excellent regarding the outcome and regarding the side effects and the time for treatment, because we use VMAT is just 3-4 minutes of treatment only. So patient can tolerate that, not like IMRT sometimes used to take 20 or 25 minutes for treatment, especially if you have a full bladder. So so it's easy for now to go for learning curve already. Who plans 60 and 20, 60 grade 20, he can plan easily the cases for the SBRT. But still, what we decided that we did nowadays we are doing a demo cases. That we do a patient's CT simulation for new patients, but we not start with the SBRT. We do 2 plans. One, the usual one, which is the VMAT and the 60 grain 20 fraction. Parallel to it, for us, for our information, to see whether we are meeting the international data regarding the SBRT, we do it in the another, but we don't treat. So we'll do that demo cases for 4 or 5 cases to make sure by the medical physicist and the technologist that technologist there is no problem because he will deliver the same setup, the same thing. But mainly the medical physicist, that if he does a plan that meets the organ at risk around and the conformity of the tumor, then we say we are ready, we can start the SBRT. So everything should be really calculated, even with the experience we have. Because the worst thing is to jump from one technology without having any experience or any knowledge, you may have mistakes in that. And we also decided that the first 2-3 cases, we will send the plans to Toronto University, to our colleagues in the medical physicists, just to have a look, to see if this patient, your patient, will you do better than this plan? So is it acceptable before moving? And I remember we did this when we started SBRT for lung. We initiated probably 6 years ago. So because I treat lung also. So we did it with the MD Anderson team. MD Anderson, there are some of the best places in the world for who initiated the SBRT for lung, right? Lung 4 fraction and that's and daily, not every other day, daily 4 and that's it. So we had a course We had at that time course in 2015, master course in Jordan for 5 days in my hospital, where one medical physicist and one physician, Joe Chang, is very well known in the SBRT of the lung. They visited us. We had that for some training, some demo cases, and we put together the protocols, and then we started. Before starting, the plan was used to be to go to them in Amman Anderson to see, is it okay, everything is fine, just to build confidence in ourselves, and then we started from there. And probably we can help you guys when you have the technology. I know that you will be having new machines, which is great, right, and new technology. But as I said in the morning, beside the machines, you should have a person who will work in that machine. The technology is very important, the medical physics very important, and the doctors. So probably you can come to Jordan for like 1 week or 2 weeks where we can share our experience in few cases, right, all together, the three, together, the radiation oncologist, the medical physicist, and also the technology to see how to deliver it. And then you can start. Maybe you can send us the first few cases for us to look and to see, just to give you our opinion, then you can safely start the treatment. Any other question?
Yeah, one more.
Yeah, please go ahead.
When you were moving from the standard 45 rates to the high dose,
Yes.
what were your symptoms or what
Yeah.
patients did you have?
Well, actually, what expecting when we started, like what the evidence is there, that probably the GU, which is mainly the bladder and the urethra, the side effects will be the same. The grade 1 and 2 of the side effects within the first 3 months, what we call the acute phase of the side effects, and after that, the late. So you will find about 50 to 60% in the first 3 months of a treatment. They will have polyuria, burning, micturition. In the night they go more times so frequently for urination. It will be there, right? But it will not be worse than the usual 2 months of treatment. The same for the rectal also as well. Although in most of these studies that I've shown, there was no problem in the rectal side effects, mainly for the bladder one. Right? So the first article I showed you, it was more because they used the 3D. So for this, yes, you may have side effects that you can manage it. Yes?
The last question is that how do you measure these patients? Do you have how do you measure? So,
Yeah, the outcome, yes. You know, if we take a patient for, we have the multidisciplinary team. If I'm a radiation oncologist, my colleagues are surgeons, right? They can see the cases first, or I can see. Because usually they used to go to the urologist. But now they can be seen by radiation oncology urologist, right? And then they will do the workup to see the stage, pathology or pathology review, the MRI, and sometimes you may do the PSMA, which we have in nuclear medicine for some equivocal radiological findings. We have it for now prostate is very important, the PSMA, but not in so early cancers. So we will present in a weekly, every Tuesday, there is a meeting for the GU doctors, where the radiation oncologists are there, medical oncologists who treats only GU. The nurses, radiologists, who I showed you, Dr. Muhammad is our radiologist who is always there, pathologist, right? And also the coordinator nurses. So we present the case, like Mr. So-and-so, 65 years, he was diagnosed with prostate cancer, adenocarcinoma, glycerin score is 7, 3 + 4, BSA is 10, for example. So what options? It is no. We have guidelines that we review every year. We have written guidelines. Such patients will be offered, say, surgery or radiation oncology. Both are good, or radiotherapy. So we will refer the patient to two, to listen from both, right? And let the patient decide which way to go. Because in prostate cancer, always we say that the patient has a word to say. But other cancer, there is one way only. You have to do it. For breast cancer, you have to do surgery. You have to. Rectal cancer, you have to do surgery. But for prostate, no. So patients will be also contributing in making the decision. Once he decides to go to take surgery or radiotherapy, he'll be referred to that specific clinic. He will be treated with a surgery or the radiotherapy. Now, the outcome of the treatment will be for the follow-up with the BSA only, total BSA. Every 3 months for 1 year, and then every 4 to 6 months, second year, and then up to 5 years of the 6 months BSA.
Who is controlling? You are the main institution of the country, so they are coming back to your institution?
Yeah. Yeah.
Who's making the follow-up?
Yeah. Usually, if they are our patients, we'll do the follow-up for them. Now, in case, because 25% of our patients, they are from Arab neighbors, Arab countries. They are not in Jordan. So after the treatments, we'll write a comprehensive report, and we put our recommendation that this patient needs to be, so if he is going back to Yemen, Palestine, or anywhere around us, Iraq or Algeria, so his doctor there will do the follow-up. His doctor will do the follow-up, right? And upon our recommendation that this patient needs to be followed every 3 or 4 months by blood test to do. There is no need to do any radiological CT or MRI unless there is a biochemical failure, sudden increase in the PSA. At that time, we do. Of course, we'll follow up with our patient by the emails that he will send the results, and we document in his file, and we reply immediately that you need to do this test after so many months, whether you do it in our hospital or the other hospitals. But we do the follow-up. If he's a Jordanian and he's treated, I treated that patient, right? I'll be doing the follow-up for that patient.
So normally all the patients that you have in the country, so they are coming to the main center.
Yes.
And you are doing the follow-ups.
Absolutely.
Yes? So surgery follow-ups, radiotherapy follow-ups,
So if
they're all done
surgery,
with, yes.
absolutely. If surgery will be followed by surgeons. If hormone therapy and radiotherapy will be followed by the radiation oncologist who treats that patient. Yeah. Unless patient decided for, because Jordan is not big country, it's a small, from north to south, 4 hours drive by car. It's not that huge one, not like China or India or whatever. So most of the patients, they come because they are covered by insurance, by the government, to be freely treated and follow up, right? But if they opted to be seen by somebody else or do the follow up, simply we can write the report, our recommendation, they can take it to the whatever medical facilities is there or private hospital or doctor, and he will follow up the patient according to our recommendations. The next talk, I'll be talking about UICC, which is the International Union Against Cancer, which is based in Switzerland. And really, I was lucky to be part of the board of directors representing the Arab world for 6 years. And still I am involved in the fellowship committee and other committees of the UICC. So I thought that since the NCI, Dr. Gregory, I think the NCI is member. I was informed member of UICC, the NCI. They are member. So it is a member. So for you, especially the young generation, to know what opportunities of a training that UICC can offer, so you can utilize this. You can go for advanced training 1 to 3 months to Jordan, to the US, to Britain, anywhere you like. The opportunity is there. And also there are some like 1-year fellowship. So I wanted to share with you, and also I'll give you an example too from your colleagues from Ahmediyat Hospital. They were selected to come to Jordan for 1 month training in my hospital. We actually decided before COVID-19, but postponed, and now they will be coming in November 1st to Jordan. So what are the opportunities that UICC can offer? For the last 50 years, when we started in 1933, it was founded, the UICC, more than 4,000 fellowship have been awarded. And in my career, when I was young, I had 4 of such opportunities of fellowship through the UICC. So it's really good for you to think about it and to get these opportunities. So these actually applications are evaluated by the International Peer Review Committee, and it happens that I am also a member of this committee, that I review these fellowship and give the decision whether to accept or not. And now, because of the COVID-19, there is a new virtual fellowship that you can apply. They won't pay money for that, but for the other one month, they will pay about $3,500. And you select where to go and which hospital. They will not really interfere in that, right? But you should convince them in the application that I want to go to Britain or to Jordan for the SBRT prostate, or for pediatrics, for anything related to cancer, anything related. Whether you are a pathologist, surgeon, radiation oncologist, coordinator nurse, you can apply for this. Anyone who is really in the field of oncology can apply. So now they started the virtual fellowship, which you can easily apply for, where you have 4 sessions, 1 hour each at least, with one of the faculty to discuss some guidelines, some new technique, or anything that's in common. So these are the objectives of such of the programs: address the critical shortage, because we know we have a problem with the skilled healthcare workers, and we have to improve that. Expand international and regional collaboration. Like when Dr. Maria and Ludmilla will come to Jordan in November, probably this is a part of the collaborative network where we can know each other and we can work together. So it's really one way of having a network together. Next, please. Next. Yeah, so this is one of from Egypt who went to France for fellowship. Next, please. Now, these are very important. You should know it. And these actually, the presentation is with Dr. Gregory. Any one of you can come back for more information. So this is the most used one. And when I was young, like you, some of you, I really utilized it 4 times. It is just 1 month, and the amount is about $3,500. And you can, roughly speaking, apply any time in the year. It's always open, the application. And here you can really, it takes 60 days for the decision to be made. And once it is agreed, they will just communicate to the applicant that you are selected and you can go for this. There is another one. This is the easiest one. There is another one, the study study grants, which is 3 months of training, and the amount is around $10,000 that you can apply for as well. This is the newest during the COVID-19, the virtual fellowship. Again, anytime you can apply, minimum 4 sessions, each 1 hour. You can have a video with your mentor, with your professor, anywhere in the world you select. And you can talk about cancer control professional working with the ICC full member. And NCI is a full member of the UICC. Next, please. So this is the application, simple. It is online application. You can fill it in. And it will be here a peer-reviewed committee, and I am a member of this committee. And then within 60 days, there will be the decision. And once decided, you can go travel. And if there is no travel, virtual. But still, for Jordan, you people, you can travel. You can come. If you are vaccinated, there is no problem. You can have the training and then in the report, and you have a certificate of the fellowship. And once you have the certificate of fellowship, you will be invited to be member of Association of UICC Fellows, which is really very important. Because, every 2 years there is a conference for UICC. You can apply, you can have a discount, you have there is a meeting, special meeting for fellows. There are many activities with that. Next, please. Now, this is the technical, which is the one that I talked about, and your colleagues from Ahmed, that they got it. So it's clinical, anything related to the treatment of cancer, anyone can apply. public health also, even the epidemiologists, the cancer registers, they can apply for this fellowship research, even in the research. Next, please. So this is the new virtual fellowship in which you can see here, this is one from India, one applicant who got accepted, and with a professor from France, they discuss an issue between, you know, something related to the activity or the service that she is in. So this is also, you can apply for that. And if you have any question about how to apply and any advice where to go, please ask me or Dr. Gregory. I'll be really there to help you. Next, please. Now, if you look about the long-term impact of such fellowships, 99 satisfaction, 99%, 87 long-term collaboration. You know, because that is a step to build collaboration between you and the hospital where you go and you visit, or the professor or the faculty. 80% disseminated skills. The one who will be trained will go back really to teach or to educate other colleagues in the department as well. Now, increase in professional growth, 98% as well. That's helpful for the career to improve. 80% positive impact in the home institution when they come back. Today, when they start a new technology, or even by increasing their skills in any field that they are treating cancer, there is an impact positively on the patients and the hospital as well. Positive impact on cancer patients, of course, this is our aim, our target is 84%. Next, please. So there are this, actually the UICC work with many partners because they need funding for that, because they are paying for the participants or for the applicants. So there are many actually bodies here. It is good to mention that they are helping the UICC to cover the expenses of this fellowship. Next, please. Now, the online learning, this is really important. There are some courses online, so you can take part in that. Next, please. Now, the online learning, actually, in 2014, before COVID-19, about 26 tailor-made master courses. Tailor-made in the region, like in Ukraine and the other countries around. They will just ask them, what really course that you need nowadays? What's the burning or the hot areas or the field you want? Say, for example, breast or prostate or pediatrics, whatever, they will select. So they will tailor this master program according to that, right? And even the faculty, they may choose a faculty from the local faculty and international faculty as well. So this is really very important to take, to keep it in mind and to apply for. And so far, more than 900 learners have took, or have participated in these master courses. Next, please. So in the master course in 2018 and 22, the model has been a bit changed from the in-person to in-person, and now we have the virtual one because of the COVID-19 pandemic. Next, please. So what's the aim of this? The courses recently offered nowadays, they are access to the essential cancer medicine, that each and every hospital should have that list of the medicine. They should, right? I'm not talking about immunotherapy, target therapy, maybe that's extra, but there are at least 20 to 40 medications or chemotherapy. They should, each and every cancer hospital should have it. And also the other one, integrated radiotherapy in the national cancer programs, patient engagement for better cancer control, managing sustainable and effective cancer civil societies organization, and the financing this in the cancer control. You have to convince your parliament members, your stakeholders, your presidents of that country, the prime ministers, politicians, that this is really important to invest in cancer treatment and cancer control. Next, please. So these courses will help you how to do it, indeed. So the online, again, here is really like over 97% respondents to the post-course. After they did the course, they have to fill up a post-course survey. 92 plan to implement Now, after attending this course, 92% of them, they really plan to implement changes in their daily work with the new skills and new information that they have. And over 95% will recommend UICC online courses to their colleagues after attending these courses. Next, please. These are some testimonies from different participants. Next, please. Positively one. Now we have another one, which this is the last project that I'll be talking about, which is the ECHO. It is online collaborative in breast cancer. So if you treat breast cancer, this will be very helpful to you. Next, please. They formed actually a project to treat breast cancer from all aspects and to think together. And so many international Cancer Institute, actually they took part in this to try as a network, to try to think together as a project here how to tackle breast cancer, and that is from the early detection, from awareness, from treating local disease, advanced disease, the survivorship after curing the patient, what protocols you have to follow for survival, for how long you should follow up your patient, what you do from investigation, so you don't do over investigation or less investigation. Next, please. And so far, these are the countries that they took part in this project. And unfortunately, you don't see Ukraine here. So if you are interested, let me know, so we'll try to be in that project. But Jordan is there. This is Jordan here, King Hussein Cancer Foundation. You can find it here. So there are many countries. Simply other countries, they are not part of this because they don't know about it. As simple as that, they don't know. So that's why I'm now disseminating this message to you and probably to others, that there are so many opportunities that you can be in and you can benefit by being in such of the international opportunities and programs. Next, please. And these are the faculty for this breast from different countries. Next, please. These some of the testimonials how they really got benefit from this. Next, please. And this is my last. I would like really to thank you again for listening to this talk. And really, it's a call for you to think about it. There are many international opportunities that you can utilize, you can apply, and we in Jordan at King Hussein Cancer Center will be there to help you identifying these areas and opportunities.
There are a lot of programs that you have shown now. First question is, are they your own local programs or they are like international ones?
The European School of Oncology, which I'm a faculty there also, they have programs. The thing you have to search for the opportunities, for the ways where internationally try. So UICC is one example because I served there for 6 years as a member of board of directors, and still for the fellowship I'm still active in that committee. So I want to pass this information to you as an example that there are some opportunities and there are some funds that these organizations will offer. If your hospital doesn't have the budget for one reason or the other, which always I say there should be a budget for training, right? It's not only to buy new machines or new technology or to expand, build a new hospital or new building. It's great, but you should work in the persons that who will take care of that to invest in their education. Still, all of us, junior or seniors, we have really to upgrade our knowledge all the time, including myself, of course.
But the question, what is the scholarship program that is controlled by your institution, and what is the best, like the easiest way to get our young doctors to your institution? Right. So for the short term, not for long term.
Now, there are two ways to do that. One way is through the collaborative agreement that we will sign tomorrow with the NCI, and we are really proud to be signing tomorrow this agreement. So under this agreement, if there is like a budget allocated for the junior or senior faculty, irrespective of whether senior or junior, they want to come to Jordan for the advanced training in 1 to 3 months, 2 months, we'll be deciding later on, depending upon the experience and depending upon the field that will be trained. Now, I know that there is some problem with the language, right? Because they're scientifically speaking, I mean, everything is in English regarding the notes and the guidelines, everything in English. So still we have interpreted the translators. We have some Ukrainian staff in my hospital. They are from Ukraine, right? In physiotherapy and the others, you know, because they married with the Jordanians, so they are there, they work with us. So the language and the translation won't be that major problem. There are many, about 5,000 Ukrainians, they live permanently in Jordan. They have families there. So there are services of translation. There is no problem with that. So either through the collaboration that Dr. Gregory will send me that this colleague will come for 1 month in this area, whatever you call it, anything related to cancer treatment or diagnosis, we can manage that, number one. Number two, through utilization of such opportunities like UICC, like your colleagues, as I mentioned, example, Dr. Maria and Dr. Lodmilla from Ahmedid, they applied. I also helped them in the way of how apply, and they got accepted to come to Jordan, and that will be covered by UICC. They will give them around $3,500, which is enough for 1 month expenses in Jordan. And even for the European School of Oncology, they have some fund and they have some, but not to Jordan, to go to Europe to do it. So I'm speaking in general, not only because to come to Jordan. Still, you can go to France. There are a list of hospitals in the European School of Oncology that you apply, and they give €2,000 per month. You may stay 3 months or 6 months. So there are different opportunities, yes.
Yeah, but having this opportunity, having you here, we want to collaborate straight ahead.
So tomorrow we are signing this agreement, yeah.
And it's for sure that Professor Klimuk have explained to you that we have a huge problem with the medical staff. We don't have such opportunity to have 3,000 people of the medical staff in the institution. So the amount is like 4 times less than you have. But it's for sure that for the caring after the operations, after the transplantations of especially in the center of the transplant. So it's completely different, the patient care. So maybe the staff of the medical staff, the young medical staff, could go for a short period stay. There is no need to apply for this fellowship, for the long fellowships. So if there is opportunity, we'll be more than grateful to have it. Yeah, thank you.
Sure, because today, in the morning, we had a meeting with the director of the NCI, very nice gentleman. So, and we listened really about the ambitious plans of future project that you have for 5 years, building new, renovation, new buildings, or some buildings existing, and some new buildings are on for the construction. And really, we were very impressed by that you have a plan of expansion. But we mentioned also the importance of a training for personnel who will run these new services and in new buildings. It is not only the buildings, it's not only the technology or the operating theaters. You need the people to be skilled enough and with good experience and with the good training to go in and to work. And that's why we are thinking together how we can do it, how we can collaborate, because your situation was our situation 20 years ago. So there is a point that you have to start from, right? Even whatever obstacles, whatever problems you face, but still there are some solutions.
Hi, good afternoon, everyone. My name is Hassan Hashem, and I am a pediatric hematologist, oncologist, and bone marrow transplant physician working in Jordan. I graduated from my medical school in Jordan, and I got training in the United States, both in oncology and bone marrow transplantation. So currently I work at King Hussein Cancer Center, and I deal with transplant patients as well as leukemia patients and other pediatric cancers. So thank you for the invitation, and it's a pleasure to be with you here today. I'll try in my first talk to talk about and introduce about bone marrow transplantation. And I'll show you some of the data that we have and what we do at King Hussein Cancer Center as well. So let's start with the history of transplant. So since we're going to talk about it. So it started really in 1940s when the atomic bomb precipitated research. And that was the exact time that scientists started to think of bone marrow transplant. In 1956, it was the first successful transplant by Dr. Donald Thomas. He received the Medicine Nobel Prize in 1990, so almost 40 years after he did his first transplant. In 1968, this was the first successful HLA-matched sibling transplant. So that was the first sibling to give stem cells for his sister. Later on, in 1973, this was the first unrelated transplant through registries. And this was from Europe to the States, actually, when they moved the stem cells. Later on, the cord blood transplantation has started. In 2010, it was the rise of haploidentical transplantation, which means taking stem cells from a family donor who is not really matched to the patient. And this has changed the field of transplantation and allowed for more transplants to be done for every disease. So this will give you a hint of how many transplantation is being done for each 10 million population. And you can try to do this for Ukraine while you're looking at the data. So if you look at North America, there is a total of 560 transplants per 10 million population. So if you look at Europe as a whole, there is a 439 transplants per 10 million population. At least this is what is being done now. So for the East Mediterranean region, which I live, there is on average 36 transplants per 10 million population. So for example, Jordan is a 10 million population. We do close to 300 transplants a year. So that will be close to here. But there are many, many centers around us that barely do this. So that's why the average is here. So for Ukraine, you expect, you do close to 100 maybe per 10 million. So you expect it to be like here, but you can guess how many transplants are needed to be done in Ukraine from this graph. So let's go back to the basics of transplant. So basically, what we do is you have to get a progenitor stem cells and infuse them to be reconstituted into the bone marrow. So this is the mother cell, or this is the progenitor cell that you really need to take out. And this will divide and give you all the other immune cells and blood cells that you need after transplantation. So why do we do transplant? So basically, you do it for one of three reasons. The first is to eliminate and replace a diseased bone marrow, a poorly functioning or failing bone marrow, and if there is an immunocompromised bone marrow. So all of these, you have to replace it with a new cells. Or to establish an immunological platform for immunotherapy. So bone marrow transplantation is the prototype or is the basics of immunotherapy that we are seeing these days. But this is an old procedure for an immunotherapy because you can have a graft versus tumor effect, which is really the immune system is trying to attack the cancer cells. The third reason, it's a way to give higher doses of chemotherapy to kill tumor, which is what you do on autologous transplantation. So basically, autologous transplant is just a way to give higher doses of chemotherapy that patients cannot tolerate. And what are hematopoietic stem cells? They are just cells that are able to differentiate into all types of cells, whether blood cells or immune cells, and they can self-replicate. So where do we get the stem cells from? So there are many ways to get it, but usually we prefer to do them in children from the bone marrow, which is the iliac crest. This is the most common location. And basically the patient will be either prone or on the side, and then you get stem cells from the posterior superior iliac crest. But there are other sites that we will discuss later, including peripheral blood and cord blood as well. So why are we seeing more and more transplants now? So currently, as of this moment, there is almost 1.5 million transplants that has been done since 1956 when the first transplant was done. So every 3 years, to 5 years, they almost double, which means that more and more transplantation is being done in every country. And the reasons for this is because transplants historically is a complicated procedure. It's risky and patients can die. And the chance of dying is more than 10%. But this percentage is going down and down every time. And we have better antifungals, we have better antivirals and preemptive treatment, effective antibiotics. Treatments for GVHD, steroid refractory GVHD, are improving. The HLA typing, looking for donors, is also improving with the high resolution techniques. And also the chemotherapy regimens that we do are getting less and less intense with the same results. And there is more and improved competence worldwide. So types of transplants, like we said, there is the autologous transplant, which is basically a high-dose chemotherapy with a stem cell rescue, which is the more accurate name, because really it's just a way to give a higher doses of chemotherapy. It uses the patient's own cells, designed to kill the tumor and overestimate the resistance. And we mainly use it for neuroblastoma, some brain tumors, and Hodgkin lymphoma. We use it for other diseases, but those are really the three main diseases we use it for. Allergenic transplant could be matched related. So someone from the family that is full matched to the patient, or matched unrelated when you look for other donors in other registries, or umbilical cord blood, or haploidentical. So those are the 4 types of allogenic transplants that you can do. Still, match related is the most common, and match unrelated donor is constant every year. So cord is decreasing, so people are doing less and less cord blood transplantation, and they are realizing that haploidentical is actually increasing. And this is for many reasons that we will discuss later. So what diseases do we do transplant for? So we discussed the autologous transplants, which you're familiar with. But for allogenic, so we do it for malignancies, and mainly it's for leukemias. We do it for some lymphomas when the autologous transplants fails. We do it for myelodysplastic syndrome and some allogenic transplants for neuroblastoma. We do it for inherited bone marrow failure syndromes, which Fanconi anemia is an example of this, but there are like more than 8 syndromes nowadays that can cause bone marrow failure, and it's all inherited. We do it for aplastic anemia, especially the severe type. We do it for hemoglobinopathies, mainly the thalassemia and the sickle cell disease, and for many metabolic diseases and for immunodeficiency. So this is a bone marrow that is filled and packed with leukemia cells, and those are the blasts that you try to eradicate when you give the allogenic transplant. So first you give the chemotherapy to clean this and make it empty, and then you infuse the donor cells to repopulate the bone marrow. So we don't do transplants for all leukemias. So still the chemotherapy is the main treatment for leukemias. So when do you need to think to refer a patient with leukemia to transplantation? Well, for some reason it's not here, but basically you refer all patients with leukemias after they relapse. So you don't do transplants upfront for leukemias except for rare cases, including those with the unfavorable cytogenetics and those who are refractory to chemotherapy treatment. And the indications are increasing with time to go for an upfront transplant, but in general, any patient who relapses after treatment should go to transplantation. Bone marrow failure, so we talked about this. And these are the bone marrow failure syndromes that we see. Fanconi anemia is the most common. Aplastic anemia, severe congenital neutropenia or Costman syndrome, Diamond-Blackfan anemia, and a whole list of inherited bone marrow failure that you need genetic testing to figure out. Aplastic anemia. So basically this is a good bone marrow when you look at it, and this is an empty bone marrow replaced by fat cells. So you can barely see only some of the hematopoietic stem cells. This is a severe aplastic anemia bone marrow that needs transplantation as soon as possible, or the patient will die of an infection or bleeding. Hemoglobinopathies, sickle cell and beta thalassemia are two indications to do transplantation. Immunodeficiency syndromes from Wiskett-Aldrich syndrome, chronic granulomatous disease, familial HLH, Shide-Kigasi, and hyper-IgM. And those are really the most common immunodeficiencies. But if you look at how many diseases we are at right now, it's close to 400 genetic defects that can cause immunodeficiency, thanks to the whole exome sequencing. Metabolic diseases, we talked about osteopetrosis, and why allogenic transplants work for metabolic diseases. It's basically because the problem is an absent enzyme that is secreted by the hematopoietic cells. And when you do transplant, you give the patient a new hematopoietic cells that can differentiate into macrophages, and these macrophages can secrete this absent enzyme. Some of the things that you need to establish a bone marrow transplant unit is, there is a lot, but some of these things are basically single patient rooms. These needs to be HEPA filtered to prevent airborne fungal infections, which could be very serious in an immunocompromised patient. This filters should be replaced regularly. At least they should have 12 air exchanges every hour. Especially if there is constructions around, this will be very, very important. Negative pressure rooms. So the patient should be on positive pressure rooms, but if they get a disease that is transmitted by droplets, they should move to a negative pressure, like COVID or measles or zoster. Flowers, whether fresh or dried, and plants are prohibited. Visitations should be really strict, and routine examination equipment should not be transferred. So when we talk about allogenic transplants, we divide this process into a few steps, at least 7. So the first one starts with a pre-transplant workup. So the patient will come to your clinic or will come to be admitted, and then you have to do some workup to figure out if he needs transplant and to look up for a donor. Then you have to determine what chemotherapy you need to give. Then you have to get stem cells to infuse them. They will be really potentially sick in this phase of a neutropenia that may last for 2 or 3 or 4 weeks sometimes. And then if transplant is successful, we call it the engraftment phase, and then there is a long follow-up in the clinic that is very frequent in the post-engraftment period, at least for 6 months. So to talk about the first phase is the pre-transplant workup. So mainly you need to screen the patient for any infections. So you want to make sure he doesn't have any viral infections. You have to do scans regardless if he is symptomatic or not to rule out any hidden foci of infection. You have to screen for organ functions. You have to look for the heart, the lungs, and the kidneys to make sure he can tolerate chemotherapy. And you have to do other psych testing, dental testing, and all other tests to confirm diagnosis. Choosing a donor is another complicated thing, but as we said, you look first into the family to see if there is a full matched sibling or parent. And then if you don't, you have to look for other registries, whether it's a national registry, if it's available, or it's international registry. In Jordan, we don't have a national registry. So if we don't find a match-related donor, we look for an unmatched donor in the family. The advantages of this is it's quick. You don't waste time, especially if you have a patient with leukemia or someone who needs transplant urgently. And it's available for almost any patient. And basically, you need to do this in a molecular lab. So HLA typing for the mother, for the father, and for all children, the patient and his siblings. And HLA is just one factor to choose a donor. So sometimes you will have more than a matched sibling, but there are other factors that it will take into consideration to choose. One of this is it's a male or a female, because some studies show the female to female is better than a male to female, but this is a minimum factor. Other important factors, the blood type, the CMV status of the donor and the recipient, how old is the sibling, will you be able to get, the younger is usually preferred, but you need to get a good stem cell dose. So if there is a patient who is 17 years or 16 years, and his only full match sibling is 3 years old, sometimes you will not get enough cells just because of the difference of the weight. So sometimes going for a haplo is what you really need to do, and instead of doing this harvesting in a toddler or a baby. So the conditioning regimen, like we discussed, so autologous is usually myeloablative. For allogeneic, if you have a leukemia or a cancer patient, you have to give myeloablative. And what does myeloablative means? It's basically a very high dose of chemotherapy. You really eradicate and ablate all the bone marrow, and then you do the infusion. But with time, there are other less intense key conditioning regimens that you can do for non-malignant diseases. And this what make non-malignant transplantation is really widespread, because reduced intensity can do the job instead of the myeloablation, but because they can do immunoablation. And those are two important terms to differentiate from. Myeloablation means to eradicate everything in the bone marrow, just eradicate all cells. But immunoablation is basically you want to eradicate the immune system of the patient so that they can accept the new graft. You don't need to ablate all the cells regardless. Mainly the T cells are what's important. And how do you choose? Basically, like we said, based on the disease. So malignancy is myeloablative. Does the patient have any comorbidities? One kidney, what's his GFR, what's his heart looking like, and basically what type of transplant and disease. This is just a summary of what I discussed. So for leukemias, you do very myeloablative, and the intensity will go down if you're going to an aplastic anemia or a genetic disease. And sometimes for SCID patients, severe combined immunodeficiency, you can go without giving any chemotherapy in certain cases. So we talked about bone marrow as a graft source, but sometimes we need to do peripheral blood as well. And there are so many factors that you take into consideration to decide, with some advantages and disadvantages of each. So here is just a pheresis procedure. You get more stem cells with peripheral blood compared to bone marrow, and you give the donor GCSF, but the chance of graft versus host disease will be higher. And haploidentical. So this is what everywhere in the world now you can see transplants are on the rise. So we talked about the advantages of this because it's available for almost all donors, even if you don't have a registry or you don't want to deal with other registries, if you don't have the luxury of time, and you use cyclophosphamide after transplant. So you give chemotherapy before, but you give cyclophosphamide after transplant, and this is the way you do haplotransplantation. Neutropenic phase. So this is the time when you are really set up for infections. And important supportive care, nurse management, and empirical antibiotic therapy are really the mainstay of successful passage through this phase. Complications. So first thing after the neutropenic phase is to make sure there will be no graft failure or rejection. And if you pass this, then you worry about the graft versus host disease, which means the graft will start to attack the host tissue. Then viral infections, bacterial infections, and fungal throughout the first 100 days of transplant. If you're talking about a malignancy, you worry about relapse, and then regimen-related toxicities early post-transplant. Graft failure, luckily, it's very rare in malignancies. It's just more common in non-malignant diseases. You barely see any graft failure in malignancy. I think in the last 5 years, we've seen it only once, and it was in a 2-year-old girl. But usually you worry about thalassemias, sickle cell, hemophagocytic lymphohistiocytosis, and osteopetrosis. Those are like the main diseases that you worry about graft failure. Graft versus host disease. So this can happen anytime. And this is really the complication that will make you scared to do transplants for patients. Because infections is one, but then GVHD is the complication that you worry about. Because it's just a disease by itself. So you can replace a disease by another. But moreover, GVHD can kill you if it's really severe. And it can be acute in the first 100 days or chronic if it happened after day 100. And for the chronic form, it can involve any organ, not just the liver, the skin, or the GI tract. You know, some examples here about acute GVHD. It's usually a skin rash, could be mild, could be just erythematous, but really sometimes could be like burns, and this is what we call stage 4, and the patient looked like he's really burned unless you start treating early. And it could happen in the mouth, it could happen anywhere. Because it's too dangerous, we really don't wait for GVHD to happen. And usually you have to start giving medications as prophylaxis. So likewise, you give acyclovir and Bactrim for infections. You give some of the medications to prevent graft versus host disease. Cyclosporin, tacrolimus, methotrexate, MMF. So there is some combinations you can try with and give it. You don't give all of those. You only give 2 medications usually. And there is a whole list of organs that can cause chronic GVHD. So sometimes the patient, so one time I saw a referral for a 9-year-old patient who weighs only 9 kilograms because of chronic GVHD. He's immobile, he cannot move, and he has so many contractures, so his mouth is almost shut that they feed him only with a syringe. And this is how bad GVHD can be. So usually patients spend 6 weeks in the inpatient unit for allergenic transplant. And once they have stable counts, they are engrafted, no infections, they are feeding by themselves, no IV medications, everything's switched to oral, no pain, you educate them and they can go home. Then they follow up in the clinic, starting with 3 times per week and then 2 times per week in the BMT clinic. You do chimerism analysis, which is just to see how many donor cells and how many recipient cells. This can be done by FISH XY, if it's a male to a female or a female to male, or by PCR testing if it's the same gender transplant. And you follow this every month for the first 3 months, and then at 6 months, and then at 1 year. The immunosuppression, which is the medications you use for GVHD, you start to taper those according to the disease and the protocol. And then once the immune system is fully back, you give them back their immunizations. So day 100 is really a big milestone because most of the complications for allergenic transplants happens in the first 100 days. So when we get referrals, we like to keep the patient at least for 100-day post-transplant. And when they are doing fine, they go back to their country usually. So I will end with some of the transplants that we do at King Hussein Cancer Center. So this is basically, we started in 2003 and we did like 54 transplants a year, both for pediatrics and adults. And with time, it went to 230 in 2019. I think it was close to 280 the year after that. And we're trying to approach 300 hopefully soon. So the majority are adults, 58%, and 42% of what we do is for pediatrics. The majority is hemoglobinopathies because we have so many thalassemia patients in our area. And then the rest is bone marrow failures, some immunodeficiencies and inherited. So this is for the non-malignant diseases. And of course, malignancies are more than non-malignancies. Most of those are leukemias. And we just published our experience with this haploidentical transplantation last month. And just using this, not for cancers, we just published this for non-malignant diseases. So we had 44 patients, and basically those are the diseases that they had. Some of them had immunodeficiencies, some had bone marrow failures, aplastic anemia, some metabolic, and only a couple of patients with hemoglobinopathies. All underwent haploidentical transplantation because there was no full matched donor. I'm not sure if you can see here, but basically our survival was close to 89%. And event-free survival was close to 78%. So there were some graft failures. But we have very low rate of GVHD. So the acute GVHD was only 20%, and most of it is mild and moderate, but there was no severe GVHD. Chronic GVHD was only 6%. And this is our team. So some of the physicians, nurses, specialists who are on call, in the unit and part of the transplant team that I talked to you about. So thank you. Yeah, so as I showed here, so in 2019, we did like 250 transplants between children, yes, in our center, children and adults. Children were 80 to 90, and the rest were adults. But most of them are allergenic.
You made transplantation only for oncologist patient or different disease?
Different. 58% were malignancies, and 58 and 42% were non-malignant diseases, the ones I showed.
In your center, yeah?
Yep.
Yeah, thank you.
This is our center data, yes.
Ah.
So my second presentation will be trying to demonstrate the importance of whole exome sequencing. It's a kind of genetic testing that we are using it more and more, and I will try to simplify my idea and try to deliver the message through a true story that I had with a patient a few years back while I was in the States. So we'll start with the case. So this is a 5-year-old male who presented with anemia and reticulocytopenia when he was 3 years of age. His past medical history was significant for many problems, but one of them is hemolytic anemia of unknown etiology at birth. He had ITP when he was 2 years old. He had alopecia areata. He had recurrent aphthous ulcers, strabismus, recurrent fevers, eczema, low immunoglobulins, and recurrent sinonasal and ear infections. But he presented with anemia and reticulocytopenia at the end. So his exam was not significant except for a large liver and spleen. So what we did for a workup for him, so we did a CBC. His white count was normal. His hemoglobin was low, as expected. Platelets were normal. ANC was normal, but his reticulocytes were actually low. So he had anemia and reticulocytopenia. His ESR was a little bit elevated. Other tests like MCV, hemoglobin F were normal. We did viral workup to exclude any viral infection because of his reticulocytopenia, including EBV, CMV, adenovirus, HHV6, parvovirus. They were all negative. Immunodeficiency workup, so we did flow cytometry. It showed elevated T cells, low B cells, and low NK cells. His immunoglobulins at the time were normal. We did a bone marrow eventually, and his bone marrow was normocellular, but there was no erythroid precursors. And he has some increased T lymphocytes. So this is his bone marrow. If you look at the figure above, this is his bone marrow. And this red stain is the glycophorin A, which stands for erythrocytes. So he barely had any erythroid precursors. This is the normal bone marrow when you stain for erythrocytes. It should be full. So accordingly, he was diagnosed with pure red cell aplasia. So what we did for this patient, so when you have a patient with a pure red cell aplasia, sometimes you think it could be transient, like transient erythroblastopenia of childhood. So you observe him for a month or two, but unfortunately he continued to require blood transfusions. So next step, we did IVIG, high dose, 1 gram per kilo. I did it twice, but no response. And then you go for the first line treatment, which is steroids. You give a high dose of steroids and you wait for 2 to 4 weeks. Usually you see the response in 2 weeks, but unfortunately, no response. He continued to require blood every 3 to 4 weeks. Then you move to the second line agent for a pure red cell aplasia, which is cyclosporin A. And nicely, he had some response here and he became transfusion independent. But this is not the end of the story, because 6 months later, after he responded to cyclosporin, and he was still on cyclosporin, he relapsed, meaning he presented with, again, low hemoglobin, low reticulocytes, but in addition, now he has low ANC and he was severely neutropenic. But his platelets were normal. We did a repeat bone marrow, showed the same findings, but decreased granulopoiesis expected because of his low ANC. My MDS panel was negative, no trisomies or monosomies, and we did all the viral workup, including parvovirus from the bone marrow as well, that was negative. We tried another 2 agents. We tried MMF, or mycophenolate mofetil, or Cellcept, and sirolimus. And both of those failed to improve his anemia or neutropenia. So to summarize the case, if you look here, so IVIG prednisone, no response. This is hemoglobin, so his hemoglobin kept going up and down, and he needed blood transfusions. We give cyclosporin. This worked, kept his hemoglobin here above 9, so no transfusions, and then he relapsed after 6 months, and he kept needing blood despite MMF and sirolimus. ANC, it became below 500, and some ups and downs. And then here, after the relapse, his ANC most of the time was below 500. Platelets continued. He had ITP, like I mentioned, as part of his past medical history. So that was before. But then when he developed this pure red cell aplasia, his platelets continued to be normal. We did more tests to figure out what's wrong with this patient. So we did autoimmune lymphoproliferative syndrome, ALPS. And this is flow cytometry that was negative. We did Fanconi anemia genetic testing. Those are 16 genes. They were negative. We did Diamond-Blackfan anemia because you would suspect Diamond-Blackfan anemia and pure red cell aplasia are close. But despite this 12-gene testing, this was negative too. So finally, we did whole exome sequencing. And this was in 2015. Because when you fish for a gene and you find it negative, then you want to fish larger and try to find if there is any other genetic testing that this patient might have. He had so many problems that coincidentally he had to have a genetic disease. And then while waiting for the results of the genetic testing on doing literature review, we found this abstract from ASH, American Society of Hematology, in 2015. It's called Adenosine Deaminase 2 Deficiency as a cause of pure red cell aplasia mimicking Diamond-Blackfan anemia. So if you look at this case in the abstract, it fits the case I presented more than 80%. So we are waiting for the exome, but there was only one abstract in the literature that describes this deficiency with pure red cell aplasia. There was no papers, nothing, just one abstract. And it was from the same year. So guess what? Not surprisingly, the whole exome sequencing showed compound heterozygous mutation in this gene, CSER1. One mutation is inherited from the mother, and the other mutation is inherited from the father. And so the patient is compound heterozygote. But if you look at the conclusion of the results from the genetics lab, it's a variant of unknown significance. So, you know, when they report whole exome, they can report it as pathogenic, which is, it means, yes, this is a mutation that can cause this disease. We are sure of that. But when they are not sure, they can say it's variant of unknown significance, meaning we don't know if this mutation can cause this disease or not. It's just there. And upon looking at this disease more and more, there was an enzyme that you can test for. So there is this genetic testing, but then when you found it, you test for the enzyme. And this is done in only one lab in the US at the time, Mike Hirschfield from Duke University. And the normal is 4.8. The patient had low ADA2 enzyme level. So he was really diagnosed with DADA2 or deficiency of adenosine deaminase 2. So after so many tests and 4 years of symptoms and diseases and complaints, it turned out that this patient has DADA2, not pure red cell aplasia, not Diamond-Blackfan anemia, not hemolytic anemia. It's just all manifestations of one genetic disease. Soon after, there was a conference named with the DADA2. So it is a very rare disease, but there was this conference and foundation that were done. And many scientific attendees, including physicians, scientists, MDs, and PhDs, and nurses attended actually this conference. And I guess the people who attended the conference were more than the number of the patients in the world at that time. There was only 80 patients, but 120 people attended the conference. And that was in 2016, and it's done every 2 years now, which is, it's really rare for a rare disease to have a conference by itself. It was the first of a time. So what is DADA2? Basically, this is a new disease that was discovered only in 2014. So the patient we had was in 2015. So it's not surprising that nobody knew about it and only 60 patients or 80 in the world at that time. And two separate groups discovered that it's a genetic autosomal recessive mutation in this gene on chromosome 22. And it encodes for this enzyme. If you know SCID or severe combined immunodeficiency, it's the same adenosine deaminase, but it's type 1, not 2. So there are very similar diseases with similar mutations, but so different manifestations. And basically, here is ADA1 that causes SCID. It is an enzyme that works inside the cell, but then the ADA2 has to go in, to go out of the cell and work outside. So it's an extracellular enzyme. And basically what ADA2 enzyme do is that the macrophages are usually in two forms. There is the M1 and the M2. And ADA2 keeps the balance between these macrophages. The M1 macrophage is responsible for tissue injury, immune stimulation, and tumor suppression, while the M2 is responsible for tissue repair, tumor growth, and immune suppression. So for the tumor, this is bad, but for the tissues, it's good. So if you don't have this enzyme, there will be more of this M1 macrophage and more of a tissue injury and inflammation, and less of a repair. So the significance is that autoinflammation, mild deficiency, and vasculopathy. And by vasculopathy, it could be anywhere in the body. And it can happen in infants after birth and even in adults. If you see a stroke in a patient who is less than 5 years old, in a child less than 5 years old, it's a must. You should check for this condition, because strokes at this age are really low. So if you find someone with a stroke who is less than 5 years old, you should check for this mutation. Polyarthritis nodosa, usually rheumatologists see this. Immunodeficiency and bone marrow failure, it's exactly what our patients has, is the pure red cell aplasia. And you can see all of these manifestations that can happen whether in children or in adults. So any system, anywhere, it can be involved. This is some Raynaud's phenomenon, Revido, racemosa, and Livido reticularis. And you can see skin ulcerations in children and digital necrosis as well. So what next? So what happened to this patient? He failed all the immunosuppressant medications, and basically he continued to be requiring blood, and his neutropenia continued to be very low for a month or two. So if you leave him, he will die of an infection. So basically we did a stem cell transplant for him, and he received a matched unrelated donor. He received this chemotherapy regimen and he was engrafted his neutrophils and platelets successfully. He had not much complications. One of the complications is refractory thrombocytopenia. So this is interesting because this patient had a very low platelet for some time, but he had the antibody positive. So he had like an ITP after transplant. And IVIG, rituximab didn't help. But then we used sirolimus, and we used the medication, the one we discussed this morning, eltrombopag or romiplostim, and this corrected his platelet count successfully. What is really interesting, if you look here, we talked about the level of the enzyme. It was 0.6. It was low at the beginning, and then after transplant, the enzyme level went up. So there was a nice way to follow this patient by just the enzyme level, and the chimerisms were also successful. So this is also a nice observation. So bone marrow transplantation can fix your bone marrow and can fix your blood counts. But what is not really known if it can fix non-hematopoietic issues. So for example, this patient had alopecia. So this is before transplant, and he had alopecia here at this location. After transplant, this area was the first area to grow hair after that. So it did not correct only the anemia, but also the hair loss and the alopecia. And the explanation for this is because you have the enzyme now, so the enzyme can circulate in the body and correct all the other manifestations. So we published this case at that time and this was the first one because the other one was an abstract, and basically refractory pure red cell can be data too. We did this transplant, but then we were wondering, did anybody else did transplant for this rare disease? And upon collaborating with others, we discovered there are 14 patients. That was in 2017. So in 3 years after the discovery of the disease, 14 patients were transplanted, both in Europe and the States. And you can see here, so this is before transplant, and this is after. So white means everything resolved. So there was no death in any of the patients, and the survival was 100%. So all patients survived after transplant. And this is a follow-up paper that we just published last month about 30 patients of this disease. So in 2021, there was 22 centers in 12 countries. In Europe, I think there was in England, Switzerland, Belgium, France, there was 30 patients. So this is a follow-up for the transplantation. And the survival was, one patient died only, so it was 97%. So it's very unique for a transplant for any disease to have a good survival. So we just published this last month. And if you really talked about transplantation for non-malignant diseases, it's really tricky. It's easier to transplant a leukemia patient or a malignant patient because he has cancer, so he has no other option. But if you talk about any other patient who lives his life, but he just needs blood every month, or he's immunodeficient and he gets this mild infection from time to time, it's really tricky to talk to the family. And basically, to go back to the whole exome sequencing to finish this is, so genomics really has failed in detecting or doing any progress for complex diseases. But for, that's why now everyone is moving toward genomics for rare diseases, whether it's hematologic, whether it's neurologic or other gastrointestinal. And they're trying to look for monogenic diseases, the diseases that are caused by only one gene, not more than any other gene. And it's very successful for these monogenic diseases. The NGS, the rise of it was in 2010. Usually it's whole exome sequencing, and it facilitated identification of previously unknown lesions. So you see these patients, you think they are immunodeficiency, but then you discover the genetic disease. So what do you do in whole exome sequencing, basically? So you identify genetic variants, like the test I showed you. It was variant of unknown significance. Why it was a VUS? Because, like I said, the disease was discovered in 2014. So my patient, the one we published, was the first patient with this mutation. And with all what's going on, now it's changed to pathogenic. So the way you change a variant in the database from unknown significance to pathogenic is to report those patients. And with time, all the VUSs, or most of them, will turn out to be pathogenic. And you use bioinformatics and filtering techniques to get rid of those variants that are really not significant. Because first you get like maybe hundreds of variants, and then after filtering and looking at the structure of the mutation and what it will lead in the protein, you go to a few or handful of variants. So why it's important? Discovery of genetic defects in patients with immunodeficiency, immune dysregulation, and syndromes of unknown etiology. And in 2 years, 47 diseases were discovered just by whole exome sequencing. And by that, I mean primary immunodeficiencies, not other subspecialties. It's very helpful in cases in which evaluation of multiple genes by Sanger sequencing would be required. And you can extend the phenotype. So this data too, it started with just stroke and polyarthritis nodosa. But now we know that bone marrow failure, pure red cell aplasia, hemolytic anemia, sometimes pancytopenia, sometimes just mild rashes in adults could be data too. So you expand this phenotype. And the other important is this patient would have not got a transplant without knowing the disease he's having. it's really good to know when you do a transplant what type of disease you're dealing with, because you know how to follow this up and you know how to troubleshoot. Otherwise, if you want to do transplant blindly without knowing the disease just for anemia or just for neutropenia, problems will start to happen. This is a study from 2016 published in JASI. It tells you that novel genes are discovered. You know, the red color is novel genes discovered by whole exome. So when you do whole exome, there are certain good percentage in all types of immunodeficiencies that you will find novel genes. Moreover, if you look at the green and yellow, so when you do whole exome, those percentage of patients in green and yellow have changed in diagnosis and changed in treatment. So it's not just a test that you do to know. Well, it's nice you know what we have, but you can change treatment and diagnosis in 40% of the time to 60% of the time. I don't say whole exome sequencing is successful 100% of the time, but at least 50 to 60% you will change the diagnosis and treatment. Of course, there are some limitations from validation, the cost, if insurance companies covers this, and how you interpret the results, if it's an unknown significance or a pathogenic variant. It doesn't cover for everything. So if the whole exome is negative, it doesn't mean you're 100% confident the patient doesn't have anything, because whole exome doesn't cover large deletions, duplications, or intronic mutations, and you need whole genome sequencing at that time. And then you can counsel the parents. So if the parents know now they have this disease, they will know the risk of transmitting this to their future offspring. Again, so this is a common photo. It's the elephant and the blind men, and you see this in many presentations. But for here, these blind men, they don't recognize that this is an elephant, because everyone is convinced he's just dealing with something. This is with the ear, this is with the tail. And unless you have a multidisciplinary approach, which whole exome sequencing can help you with, together only they can figure out that they are dealing with an elephant. And this is a story of many primary immunodeficiency diseases. So in summary, patients with undiagnosed immune diseases are really increasing. So if you talk about a rare disease, there's only 200, 300, or 400 patients. But when you take all rare diseases together, there are hundreds of thousands or millions of patients now dealing with rare diseases. And primary progress has been made in finding these disease-causing genes, and whole exome is moving so quickly to the clinic. And it will not just help those patients with undiagnosed diseases, but also will help understand more common complex diseases and discover the relationship between the genes and the clinical manifestations. And there are so many biological agents now play a role in treating those diseases. So we will move away from transplant and rare diseases and whole exome and genetics to an old subject, which is the oncologic emergencies. I guess you deal with this here on a weekly basis or maybe on a monthly basis, but not much changed in that field. But it's just important to keep aware of the complications or the emergencies that our oncology patients will present with, because it's really important to recognize those very early and treat as soon as you can before time is over. So, despite improvement in childhood cancer care over the last 2 decades or more, many still present late with a huge tumor burden. And early recognition and treatment of those emergencies remain very vital. And with the corona pandemic, I guess we started to see, and we see more of those patients who present late, referred late or present late just because of the pandemic restrictions. And more oncologic emergencies is being seen at our center, and I'm not sure about here, but usually they present later and later. So if you want to divide these emergencies in a good way and a nice, easy way to remember, it's usually 4 major categories. One is if there is a space-occupying lesion or a mass effect. There could be a hematologic emergencies, metabolic emergencies, and infectious. So we'll talk about space-occupying mass, we'll talk about some hematologic emergencies, we'll talk about some metabolic emergencies, and we'll leave infectious for another lecture because it's a little bit different than the others. So when you talk about space occupying or mass effect, you can divide this into 5 categories depending on where the mass is and where the tumor is. And if it's occupying head and neck region, chest, abdomen, spine, and or if it's in the pelvis and causing urologic emergency. So here you can see for the head and neck, let's start with the first one, acute hydrocephalus. It's a common presentation for kids with brain tumors. And usually symptoms are just neurologic changes, headache, vomiting are very common. And you need to do a stat CT scan. And this is when you discover a hydroceph or an intracranial mass. And basically, it's an emergency because hydroceph can be dangerous and you really need an immediate shunting. Usually, you go with an external ventricular drain, an EVD, before you internalize it to a VP shunt. Increased intracranial pressure, it can come with hydroceph or without, and basically the patients will be irritable, lethargic, vomiting. You can see a bulging fontanelle in infants, sometimes separation of sutures. If you look into the eyes, you will see a papilledema, sometimes anisocoria, ataxia, head tilt, or are manifestations that are red flags for a brain tumor. And you finally, and it's late to have a Cushing's triad, which means that it's a late finding and things are not good. It's an abnormal or decreased respirations, bradycardia, and hypertension. Basically, neurosurgery consult, you start steroids, you start patients on mannitol to help decrease intracranial pressure and hyperventilation by intubating the patient and controlling his breathings. Most primary brain tumor are not sensitive enough for chemotherapy to allow for a non-surgical treatment. So if you start chemotherapy emergently, it's not sensitive enough to help these patients. You need other surgical techniques to relieve the CSF outflow, and EVD is really what you need in addition to all those measures, because eventually herniation and brainstem compression will really ruin your day, and it's the ultimate outcome if left untreated. So if we move down from the head and neck to the mediastinum, so many tumors present with a mediastinal mass. So the mediastinum here is the space that is occupied, and it's a high-risk area for both airway compromise and vascular compromise. So 2 issues that you have to deal with. And airway compromise is more in children because there's a limited chest volume and there is a smaller airway diameter. You call this, if it happened, it's a mediastinal syndrome, but then you can have superior vena cava syndrome, which is when the mediastinal mass not just compress the airways, but also presses the vasculature, mainly the superior vena cava. Majority of these mediastinal masses will be in the anterior mediastinum, and the majority of those will be leukemias or lymphomas, if you talk about anterior mediastinum. This is an X-ray, a chest X-ray that shows a huge mediastinal window. This is not supposed to be normal. This is what a normal chest X-ray are. So the mediastinum is not wide, here it's wide. So there is a huge mass here that can be compressing on the vasculature or the airways. The way to say and the way to tell is by doing a CT scan. So for example, again, a huge mediastinal window, huge mediastinal mass. You can see on the CT scan, those are the main bronchi. They are really almost very compressed. And you can see the patient and the scan is really semi-up tilt. So he cannot even lie supine because he will be really short of breath. So that's how they protect themselves. So superior mediastinal syndrome or severe vena cava syndrome. Symptoms, mainly it's dyspnea and hoarseness, shortness of breath. They can lay down, orthopnea. And if you examine them, sometimes if it's severe, you can see swelling and plethora above the obstruction, which is in the neck and face. Vessels will be distended. You can see distended vessels on the face and neck and the chest wall also. Diaphoresis or sweating, wheezing, and stridor. So how do you treat this? We usually admit patients to the pediatric ICU for observation. We put them in a prone position or lateral position, but not supine. We avoid anesthesia, heavy sedation, and any neuromuscular blockade because this will make the patients collapse. Avoid interventions without controlled environment. That's why we put them in the ICU. We eventually need a tissue diagnosis because, like you know, in oncology, this is the thing we have to get is a tissue diagnosis to start a treatment. And ideally, you don't start treatment without a tissue diagnosis. But you can get this via the least invasive method. So for example, if the patient has pleural effusion with the chest mass, so it's easier just to get a sample of the pleural fluid, and sometimes this can be diagnostic in certain cases of lymphoma, and this is the least invasive. Sometimes doing a bone marrow biopsies, because if this is a lymphoma that is spread, you can see some of the cells there, or if it's a posterior mass and you think it's neuroblastoma, sometimes you look at the bone marrow before you do the biopsy. So it depends on the case. You will choose basically the least invasive method. You maintain sufficient venous return. So this is very important. You need a venous return to maintain cardiac output because those patients will be at risk of cardiogenic shock. So you need to keep them hydrated. You need to keep giving fluids in the right amount to keep them eovolumic. And at the end, to treat, if you are in an emergency, you can give radiotherapy, you can give steroids, plus minus chemotherapy if you are unable to biopsy. So another emergency that can happen in the chest area other than the mediastinal masses is pericardial effusion that is causing tamponade. Meaning there is fluids around the heart that is really pushing the heart to cause tamponade and hemodynamic instability. Usually leukemias and lymphomas, and usually the T cell type are the ones that can cause this. And I remember like 2 patients just in the last month who presented to us with a huge pericardial effusion, but there was no tamponade at the time. And we did the bone marrow and it showed leukemias, T cell leukemia for one, and then the other patient was Down syndrome who had an AML. Treatment, cardiology consult, you do an echo, and chemotherapy basically. If you start chemotherapy as soon as possible, you can shrink this effusion without needing a pericardiocentesis. So if you have to, you can do a pericardiocentesis, but if you want to save the patient this, you have to start chemotherapy as soon as possible. And usually it's steroids, vincristine, asparaginase, and this is how you treat it. And like we said, pericardiocentesis only if needed. So now moving down to the abdomen. Acute bowel obstruction or intussusception is another space-occupying emergency. Usually it's Burkitt's lymphoma patients. So if you see an intussusception in a patient more than 2 years old, you should suspect a tumor because usually infants have intussusception. Bloody stools, palpable mass, abdominal cramps, all are red flags. You do an NG tube, you avoid enemas, you start chemotherapy, and if you need to, you will have to do a surgical intervention, which is really rarely needed. One other thing you want to avoid is compartment syndrome in the abdomen. Basically, it will cause an inadequate organ perfusion. Usually, you diagnose this clinical, but an ultrasound or a CT scan will show venous compression sometimes, and IVC obstruction is one thing that you can see on the imaging for confirmation. Possible etiologies are large bilateral whelms, for example. This is rare, but it can cause compartment syndrome or a giant ovarian masses. Those were really, you should worry about this compartment syndrome when you see this. Surgical referral, emergency decompressive laparotomy if you need to protect organ perfusion. Emergency that can happen in the abdomen is acute massive hepatomegaly. And you see this sometimes in stage 4S neuroblastoma. It's usually a tumor that can regress spontaneously without chemotherapy, but it's very dangerous and the morbidity and mortality is high if you have a huge mass. And basically, this is an example of a huge liver mass that can really cause dyspnea and decreased breathing. Patients may require intubation, and if you don't start chemotherapy immediately, they may die. Another rare emergency is an obstructive jaundice. This is, you see a patient from like time to time, once every few years. But basically, biliary rhabdomyosarcoma is an example of this. It can be accompanied by hepatomegaly. The diagnosis still is challenging after all of this because of the rarity of it. And when you do an ultrasound, you see biliary dilatation and soft tissue mass within the common bile duct. MRI, MRCP can help you sometimes, but those are very sensitive tumors, so chemotherapy can really melt them down in a matter of a week or two. And you rarely need a drain in the hepatobiliary area to relieve the jaundice before chemotherapy. Sometimes if you have really direct hyperbole and you cannot give chemotherapy because of the adjustment you need to do, or because you cannot give it because the bilirubin is more than certain numbers, you have to put a drain and wait. But there are many chemotherapies that doesn't depend on bilirubin, like topotecan, for example. Okay, spinal cord compression, another space-occupying masses can be there. Symptoms usually back pain, motor weakness, sensory autonomic dysfunction. Any of these manifestations can happen. Oncologic differential paravertebral tumor is another tumor that can cause spinal cord compression. Usually these tumors are sarcomas, are mainly Ewing and rhabdomyosarcoma, can be close to the spinal cord. Neuroblastoma is another one. Lymphoma, leukemias if there is intraspinal chloromas, but this is rare, and primary spinal tumors like ependymoma. Those are really rare as well. So here you can see metastasis from an intracranial tumor with so many deposits extending from T12 to S3. And this is a tumor that is filling all the neural foramen on the right, and you can see the spinal cord is really compressed. And by the way, this is a paravertebral tumor, likely it's neuroblastoma. This is here another sagittal view showing intraspinal extramedullary deposits here along the spinal cord, and you can see that it's pushing the spinal cord anteriorly, squeezing it. And here, if you go at the cauda equina level, you barely see you see only the tumor. And this is metastasis from an ATRT in the brain. So what's the treatment? You do a stat imaging, MRI of the spine, high-dose steroids, immediate radiotherapy, and chemotherapy if feasible. Surgical intervention if medical management fails. So for the previous cases, laminectomy with decompression is what you really need to know to save the patient's his neurologic function. Pelvis. So if you see a huge germ cell tumor or a huge ovarian tumors, usually you worry about obstructing the ureters and causing hydronephrosis. And basically the patient will have low urine output, you will have high serum creatinine, and what you need to do is an immediate decompression and drainage, nephrostomy tube placement. So from time to time you will get a patient with a very high creatinine. You think it's tumor lysis, but it's usually not. And whatever you do without a nephrostomy tube, his creatinine will be high, and he will be in renal failure, and then he will need dialysis. Once you put a nephrostomy tube, in a matter of 24 hours, his creatinine will start to drop, and then this will save the patient the dialysis. This is an example. You can see the hydronephrosis here on both sides, and this is the huge right-sided ovarian tumor squeezing on the distal part of the ureters. So we'll move from the mass and space-occupying lesion to the hematologic emergencies. Hyperleukocytosis is an emergency that we see with leukemia patients. So what's hyperleukocytosis is when you have a peripheral count of more than 100,000. Usually you see it in AML patients, some in ALL patients, and you see it all the time with the CML patients. So all CML patients will present with hyperleukocytosis. But you only worry in acute leukemia patients. The risk is CNS hemorrhage, CNS thrombosis, pulmonary leukostasis, and pneumopathy, because these cells are viscous and they can stick in the vessels and they will cause obstruction. And they can cause a tumor lysis syndrome. Symptoms: shortness of breath, hypoxia, this is in the lungs, acidosis, and in the CNS you see agitation, confusion, stupor. This will lead even to a stroke. Many will have no symptoms, so you don't want to wait until the patient has symptoms. Treatment, hydrate, alkalinize, you do allopurinol to prevent, and if the uric acid is high, you give raspuricase immediately. You can give this once a day, up to 5 days. We usually don't need to give raspuricase more than once, but you have to remember to send the uric acid on ice, otherwise it will be masked. You transfuse if you have low platelets, but you have to avoid giving blood because blood is viscous, and with the high white count, you may lead to stroke or lung issues if you give it together. So if the patient's hemoglobin is 6 or 5.5, it's fine if he's hemodynamically stable. If you really need to give blood, you only give small aliquots, like 5 cc per kilo. You don't go for a 15 per kilo or 10 per kilo. And then leukapheresis, and this is very controversial. So when do you need to do leukapheresis with the high white count? There is no strong evidence and there is no randomized trials that leukapheresis would help, because if you do this, bone marrow will push more cells to the circulation, and basically there is no benefit. But if you have really high white count, and we get those patients sometimes with a white count of 800,000 and 900,000, sometimes buying time until you diagnose the patient and do the flow and determine which type of leukemia. You know, these 24 hours will be really vital. So doing one session of leukapheresis or 2 sessions may help you buy the time until you start steroids, because, you know, those will be very sensitive tumors. But you should worry about tumor lysis with a 900,000 white count. Tumor lysis, everyone know, this is how you define it: high uric acid, high phosphate, high potassium, and low calcium. And basically, lymphoplasts have more phosphorus than lymphocytes, so that's why you worry about tumor lysis in ALL more than AML. And of course, you worry about kidney injury and kidney failure and needing dialysis. Burkitt's lymphoma is a tumor that you should worry about, or a T-cell leukemia or B-cell leukemia with a very high white count. And this is how raspuricase and uric acid basically work. So allopurinol basically prevent this step. So it's a competitive inhibitor, so it will decrease uric acid, and raspuricase basically will convert uric acid to allantoin, and this is really soluble in the kidneys and in the urine, so you don't worry about kidney injury. Management, we talked about that. Eventually, if nothing works, you will need to do dialysis for a hyperkalemia that is resistant to treatment, or hyperphosphatemia, or uncontrolled fluid overload. But usually, if you start allopurinol early and you give raspuricase when uric acid creep up, or it's more than 10 initially, this will prevent all the consequences. So a couple of cases just to affirm this is a 17-year-old male. He was previously healthy weightlifter. He had a new onset lower back pain. He was admitted on a Friday night for increasing pain. Pain was treated with morphine, PCA, but on exam he has full movement of all extremities, so all good. CT scan showed multiple masses in the liver, pancreas, kidneys, also possible intussusception. Over the weekend, he had worsening of the lower extremity function. On Monday, he had an MRI and diagnostic bone marrow aspirate. And basically, this is how Burkitt's lymphoma can present. The patient would be fine on a Friday night, but then if you wait and the mass is huge and you don't treat, it may lead to decreased power and you worry about paralysis. So this is Burkitt's lymphoma, and these are characteristic of Burkitt's lymphoma in the bone marrow. So this patient should have not waited till Sunday to be treated. Bone marrow should have been done earlier, or you should start steroids upon suspicion because he has a huge mass. Another case is a 15-year-old girl, 3-day history of oral bleeding following extraction of a wisdom teeth. She was seen at a community hospital, and CBC showed a white count of 22,000. With 83% blasts, morphology was consistent with acute promyelocytic leukemia, or type 3 of the AML. The patient was transferred to the ICU, but then had progressive multi-organ failure on the day following admission. Death was due to uncontrolled pulmonary hemorrhage 24 hours from admission. So what is APL and why it can do that? So basically, it's type of acute myeloid leukemia. It has a characteristic translocation, which makes it the best acute myeloid leukemia to have in terms of survival and prognosis. It reached more than 85 or 90%, so it's one of the best leukemias to treat. But initially, they have very high mortality rate, and 10% of patients, so 1 in 10 patients will die of bleeding if he was delayed in diagnosis or treatment. So the treatment for this translocation is vitamin A, or trans-retinoic acid. It's a simple medication that can prevent death from bleeding. And now they are using arsenic trioxide, which is a toxic compound, or it used to be like this, but here it's a medication that we can give to treat ATRA patients. We talked about the importance of treating those patients with ATRA even with early suspicion. So last week we had a patient, we suspected he has AML from the morphology. We started ATRA before confirming. We did the mutation, it was negative. We stopped the ATRA, so no harm, but you have to give it because with any delay, they may have intracranial bleed in a matter of days. Last case is a 2-year-old boy. He presented with hyperleukocytosis, and that's a patient of mine. That was 4 or 5 months ago. His white count was 320,000. Bone marrow showed he has T-cell ALL. Of course, we started him on dexamethasone. He received a dose of daunorubicin and vincristine on day 1, just like we treat leukemia. On day 4, unfortunately, before receiving the asparaginase, he was due to get this. He developed abnormal movements and decreased mentation. His Glasgow Coma scale was 9, and he had limb weakness and mutism. MRI was done, and this is what it showed. And actually, we published this case recently. So what you can see here is strokes. So this is a brainstem stroke and cerebellar stroke. This is the stroke again. And here you can see herniation. So he actually almost herniated. It was few millimeters. So, so this was the initial scan. And this was the diffusion scan showing the stroke in the cerebellum. His angiography was normal, so there was no stenosis in any blood vessels. So we assumed his stroke was due to his very high white count, which doesn't happen often, but he did not give asparaginase, he did not give any thrombogenic medications, and his genetic testing for thrombophilia was negative. How did we manage this patient? So here you can see angiography is normal, the herniation resolved, and you can see just the infarcts evolving area. So no new infarcts, and this will remain as it is. But he regained all his functions, and he's back to normal now. He's free of leukemia. We just continued dexamethasone. He was intubated because his decreased mentation status, and basically you have to continue treating. You don't give intrathecal therapies in these cases because you worry they may bleed. But otherwise, early recognition and continued treatment of this patient saved him from death.
We have several cases with a bad results. The patient died because of some situation that you described. First of all, it was the hepatomegaly, and we waited for a week for the decompressive laparotomy, and we didn't do it. But we start emergency we start chemotherapy and didn't get an replay, any answer, any replay for the chemotherapy, any reaction. And what do you think in that situation? Is it worth to do laparotomy decompressive if you have no response to chemotherapy?
What was the tumor?
Neuroblastoma.
Oh, neuroblastoma.
Hepatomegaly, yeah.
Oh. So the question is, if we don't start
to do the decompressive laparotomy if the tumor didn't respond to chemotherapy?
No, I mean, I think if we have that patient, we will do the same. We will start chemotherapy because most of those will respond quickly to chemotherapy. So you don't go for laparotomy before trying chemotherapy, especially that when you started chemotherapy, he didn't have compartment syndrome or anything that will necessitate. So I guess we still have to do chemotherapy. It's just one of those rare, unlucky ones that did not respond.
We had compartments. We start chemotherapy on compartments.
Oh, you had compartments. Yeah, then some people will do this, but some others will do laparotomy. So I think if the compartment was really severe, then I'll do compartment laparotomy to save this patient, because chemotherapy, even that it's chemosensitive, but it needs few days at least. Even with chemosensitive tumors, you need few days, and this patient will not have sometimes these few days starting from a position that you have compartment syndrome. If you don't have that, and you start chemotherapy, then you have the luxury of time to wait and hoping for the compartment syndrome not to happen. But if you already have it, I would go for laparotomy.
Okay, thank you. And when you have spine compression because of tumor, please tell us about your algorithm concerning the diagnostic and treatment. I see chemotherapy, the high-dosage steroid, but how about diagnosis if it's local tumor and you couldn't differentiate it's a neuroblastoma or ganglioneuroma, but you have the neurological deficiency?
So regarding treatment, so we usually go for radiotherapy, emergency radiotherapy.
2 years old.
Huh?
The patient is 2 years old.
Yes, we go for steroids plus minus radiotherapy. Usually we tend to go for more for the radiotherapy, especially if it was really compressing the spinal cord and is already malfunctioned. But for the chemotherapy part, you have to start chemotherapy because you don't have a diagnosis and you don't have the luxury to do this. So what we do is we put a differential for the most likely tumor we will have. So if it's a neuroblastoma versus others, and usually neuroblastoma will be top on the differential for those, and we start for neuroblastoma regimen. So we start both chemotherapy and radiotherapy. But again, chemotherapy will need few days. So that's why we'll have to do some radiotherapy with steroids to avoid this initial edema that may harm him. But neurosurgery and surgical intervention is usually, we don't usually need that. So we'll do both steroids, radiotherapy, and chemotherapy. You start all together if you need to, because chemotherapy will need some time and radiotherapy will buy you that time.
What dosage and what regimes of radiotherapy?
That's I don't have it in my
Jamal
mind. Yeah.
This is for the adult that you start with the high dose steroids and then with radiotherapy, but mainly, and that depending on whether this tumor is sensitive to chemo or not, because unless if it is lymphoma or small cell lung cancer, you don't go immediately for radiotherapy. Usually, for the adults, you go for surgery. That whenever it is possible, especially if it's not that responsive to the chemotherapy, you start all of the steroids and with surgery, and then after that radiotherapy. For pediatrics, mainly it's the steroids and the chemotherapy, and probably the surgeons will not go in because most of these cases will be sensitive to the chemo rather than surgery. So no more. More it's an adult, the rule of surgery. Usually if radiotherapy is needed, the dose will be modest dose actually, which is between 20 to 30 gray.